Assalamu alaikum. Good evening, everybody. It is our pleasure today to introduce the Thyroid Update Series. This is organized by the Arab Thyroid Association. It is our pleasure today to have two eminent speakers. The first speaker is Dr. Abdullah Al-Raouf Al-Mahfoud. He's consultant endocrinologist and the head of the endocrine section in King Faisal Specialist Hospital and Research Center in Riyadh, Saudi Arabia. He's a recognized figure in the endocrinology and thyroid cancer, and he has many publications. The other speaker is Dr. Naji Al-Jahani. He's associate professor and consultant endocrinologist and thyroid oncologist, working in obesity, endocrine, and metabolic center in King Fahd Medical City in Riyadh, Saudi Arabia. He has many publications and recognized in his field. The first presentation will be by Dr. Naji about the management of low-risk thyroid carcinoma. And the second presentation will be the management of radioiodine refractory thyroid cancer, will be by Prof. Abdul Mahfoud. Then at the end, we'll have a question and discussion. So welcome, Dr. Naji.
Thanks, Dr. Nasser, for the invitation, and I would like to thank also Arab Thyroid Association for this opportunity. Today we'll speak about management of low-risk thyroid cancer. Let's start with the case. This is a typical case in our clinic. 37-year-old woman was referred to the endocrine clinic for management of thyroid cancer. She underwent total thyroidectomy 2 months ago. The pathology showed 2.5 centimeter in the right unifocal papillary thyroid cancer. There was no vascular invasion and no extrathyroid extension. There is no lymph node involvement. She's asymptomatic, and there is no family history of thyroid cancer in her family. And also there is no history of radiation exposure. In examination, she is clinically euthyroid. The neck shows healed scar for previous thyroidectomy, and there is no mass or lymphadenopathy. Now, one question for any patient with thyroid cancer: how would you like to manage this patient? What's her risk status? And does she need radioactive iodine or no? How would you like to follow her and for how long? And what's her target TSH? There is several questions for the management of this type of cases. So this is our objective for the talk of the day. Within 25 minutes, we try to cover them all. If you see here from the statistic of thyroid cancer from state, there is almost 98.5% survival rate, which is excellent survival for the thyroid cancer. And percentage of all cancer deaths, 0.3. If we see over the last 30 years, the survival doesn't change. But the detection increased till probably 2010, but then start to plateau. And this is maybe just due to like detection, ultrasound technique, etc. And this is also another study from Saudi Arabia by Dr. Filimban. Over 30 years, they noticed that even though, if you see here, the detection significantly increased, but the mortality almost close to the same. There is probably might slight notch, but over the years, or the last at least 20 years, plateau. So here's the changing paradigm of management of thyroid cancer. The previous one is one size fit all for all thyroidectomy or for all cases like radioactive iodine therapy, and for some of them same follow-up strategy for all of them, keep them as one ball. The new paradigm risk assessment approach, we might have two cases, even though low risk or moderate risk, and they need to be treated differently. And if you see here from a long time ago, like Dr. Janaklas from UK thyroid, they noticed that the higher the stage mortality, so stage 1, most of the time, they have almost near normal survival. Stage 2, close to them, but whenever you advance the stage, there is increase of mortality. So for staging and risk stratification, the DNM updated in AGC by the AGC in 2018, primarily based on pathological finding and separate patients into 4 stages, stage 1, 2, 3, and 4. However, there is other stages, like for example, University of Chicago, they growth staging. This mainly, they said, if it is intrathyroid stage 1, if there is lymph node stage 2, if there is extra extension stage 3, and if there is mid stage 4. There is another one, Ohio National Thyroid Cancer Games. MACEs mainly based on in Mayo Clinic mainly, and probably Montreal they use it. There is several centers they use it. Mainly depend in data from ANH from Mayo Clinic for a study of 50 years of thyroid cancer follow-up. They took retrospective from 1940 till 1990, and they almost like 1,800 cases. Then they see the survival. Like for example, in low risk, the death rate is down almost 1%. And they took mainly the age. Then they have other score, like for example, the size of the tumor, the completeness of the surgical and invasion, as well as the aging and myths. And they have calculation. If you go to Google them or their site, they have how to calculate MESIS score. Actually, in MESIS, they are typically, if it is above 6, they give radioactive iodine. If it is less than 6, most of the time they don't give radioactive iodine. For example, here application, this is why we said just individualized case. For example, the first case, 56-year-old woman with PTC, post-thyroidectomy, 1.2 centimeter. There is no invasion. One
دكتور ناجي الصوت ما واضح.
out
دكتور
of
ناجي
2 lymph nodes with microscopic PTC, no distant mets. If you see, yeah, is this the sound now is okay?
Maybe he went to re-enter again. Dr. Naji with us? ممكن الانترنت connection. Maybe he will re-enter. Ziad?
Maybe I just, is it now clear, the sound?
Okay.
Okay. The second case, 52-year-old male with PTC thyroidectomy neck dissection, 1.5 gross invasion of the esophagus, incomplete resection, and there is central and lateral grossly involved lymph node, no distant mist. Again, this T4 M0, MACE is 5.7, stage 2, and low risk. So here, we don't mislead by just TNM staging or even MACEs. We need to individualize each case for those case scenario. This is what they expand actually their low risk to include even with those micromets of lymph node. If you see here, papillary thyroid cancer with all of the following: no distant mets, no local mets, all tumor resected, no invasion. The tumor does not have aggressive histological feature, and if iodine given, there is no metastasis beyond the thyroid bed, and no vascular invasion. And either no lymph node, or if there is less than 5 with micromets. It seems to be intrathyroidal and less than 4 centimeter. In differentiated thyroid cancer TNM staging, those people with stage classification, mainly they took the age of 55, because there is several studies show that even those people, initially it was 45, now 55, still even if they exceed 55, the survival or the recurrence actually significantly decreased. And if you see here, if you go up, these are the recurrence rate per percentage from ATA. If it is like, for example, multifocal, the recurrence is almost like 5% or around. So still, even if they have lymph node, but micromets and less than 5, this is again still considered as low risk. This is a cancer staging calculator from AJCC, from American Thyroid website. You just enter the data, for example, age, size of the tumor, and if there is other like invasion, etc. Then you just click calculate. They will give you the TNM, they will give you the stage, they will give you actually MACEs score and also AIMS score. Here is stratification of thyroid cancer done by Dr. Tuttle and Dr. Zahrani, and pre-diagnostic risk assessment. If the patient low risk, then you consider if we need just minimalistic management sometimes, and we'll speak about this in a minute, about just only active surveillance. There is no even surgery. And most of these data actually came from Japan, from E2 and Tikera Makayashi. If you see here, After diagnosis, after thyroid surgery, if it is done, just we will do staging and ATA. ATA mainly it will assess the risk of recurrence, and AGCC mainly assess of the risk of death. Stage 1 and 2, very low risk of death, but stage 4, there is up to 50%. When you follow up and monitoring, this depends on the response of the patient. If the patient have excellent response, probably just you can widen the bleed or indeterminate. They have very high risk of recurrence. So let's go for initial stage management. We have for low risk thyroid cancer, option of active. There's no patient they need hemithyroidectomy versus total thyroidectomy. So here in selecting patient for active surveillance, it needs pre-op imaging clinical finding, like tumor size, if it is like, for example, less than 1 centimeter or micro. The location, if it is away from recurrent laryngeal nerve or others, vital structure. If there's extrathyroid extension or no, METs or no. And the patient characteristic, age. For example, this typical for elderly is actually ideal. Even in one of the studies show that above 65, they don't even increase in size. Patient preferences, comorbid condition, patient fit for surgery or no. Medical team, you need high quality ultrasound follow-up. I have like few patients just on active surveillance, mainly because the patient refused surgery after even their FNA. But they do well, there is no invasion and there is no increment in the size over the last, some of them almost like 10 years now follow-up.
Dr. Naji, make the mic clear,
association for
يعني be near the mic. Can voice more? Yes. Yes, complete,
okay.
Dr. Naji.
Okay. This is for, yes, for active surveillance. This is from Japan. They have like studied lymph node mets over the last 5 years.
Yes,
Yeah.
Dr. Naji.
For example, Afwan?
Complete.
Okay. For example, here from other studies from Milan, most of these studies show 1 to 1.5 development of lymph node over the last like 5 years. But most of them, they do very well. And these are for indication for immediate surgery if there is presence of lymph node mets or there is invasion to either vital structure like trachea, or diagnosis of aggressive subtype, or tumor adherent to the trachea, or age or like younger age. And these are indication for surgery after active surveillance. So those patients, you follow them. If you find the tumor diameter approaching more than 1.3 centimeter, or appearance of lymph node, or change in patients if the patient choose to have surgery. This also proportion for the patient. If you see here, like in old patient, even after 5 years or 10 years, it doesn't change in size. And younger, they might increment in size, but most of these are minimal. And at any time, if there is any high risk feature, you can just switch to have the surgery for them. The goal to remove the primary tumor and accurately stage the disease, facilitate radioactive when the patient needs them, and minimize the risk of recurrence. It recommend for any patient more than 4 centimeter or gross extrathyroid extension to have total or near total thyroidectomy. If the patient having lower than 4 centimeter but more than 1 centimeter, they can have total thyroidectomy or even hemi or lobectomy. And if patient less than 1 centimeter, they can have lobectomy or even like active surveillance. And here, how can we do for people with thyroid lobectomy versus total thyroidectomy? From a study done by Lin, published last year, they noticed total thyroidectomy or lobectomy, almost 10 years survival, almost the same, doesn't change. If you see the p-value was not significant. If you see here, all the parameters not significant except radioactive iodine, and this is, it makes sense because those patients with total thyroidectomy, they can be given radioactive iodine if need, but those with hemithyroidectomy, we don't give them radioactive iodine. This is from ESMO, which is European Society of Medical Oncology. What they mention for T1A, which is less than 1 centimeter or micro, if they don't have radiation exposure, no family history, no posterior or adjacent to the trachea, and no aggressive feature, unifocal, and no extrathyroid extension, they can be followed just only with active surveillance. If they have, for example, posterior to or adjacent to the trachea, they prefer to have lobectomy. However, if the patient have other risk factor, they might need total thyroidectomy, even if they are low risk. Here, radioactive iodine for low-risk patient with well-differentiated thyroid cancer, do we need to give or no? American Thyroid Association, they don't recommend mainly for low-risk patients. If you see here, ATA, low risk, there is no need. But if the patient start to have moderate risk, for example, T3 N0 or N0 M0, more than 4 centimeter or microscopic, they consider, especially if there is like middle age or other risk factor, for example, external beam or exposures of radioactive of radiation or other risk factor. Yes, sometimes this is selective, but in a patient with very high risk, for example, if there's gross invasion or meds, they need to be having high radioactive iodine. As a rule of thumb, low risk most of the time. If they don't need, or if they need low dose of radioactive iodine. High risk, they need a higher dose of radioactive iodine. And the objective of radioactive iodine to increase the sensitivity of detecting metastatic disease, facilitate interpretation follow-up, especially like thyroglobulin level, potentially treat any residual or any local meds, and decrease the recurrence rates and improve survival. And if you see here, for those people, response to therapy. If they have excellent response, it means that there is clinical exam, they don't see anything. A biochemical TG and stimulated TG and anti-TG negative. And there is no structural ultrasound negative, and iodine scan, if it was done, it will be negative. Biochemical incomplete, if they have abnormal TG or rising TG antibody in the absence of any disease, you do imaging like ultrasound negative, and if still rising, you do PET-CT negative. So this is just biochemical incomplete, just to follow them or observe them. Structural incomplete response, persistent or newly identified local regional disease or distant meds. And indeterminate, there is non-specific biochemical or structural finding, like, for example, stable or declining anti-TG without definitive structural evidence of disease. And if you see here the response to therapy, if the patient receives total thyroidectomy and radioactive iodine, excellent response, stimulated TG less than 0.2, and in the presence of in the TG less than 1. Biochemical incomplete, there is positive TG, but everything is negative. Structural incomplete, there is structural or functional evidence, and indeterminate, non-specific finding. Without radioactive iodine, almost the same, except biochemical incomplete, non-stimulated TG will be less than, actually here, more than 5, or stimulated more than 10. If the patient have lobectomy, how you would like to follow them? Clinical ultrasound and also thyroglobulin can be even of value, even in those patients with hemithyroidectomy. Excellent response, they will have stable non-stimulated TG less than 30 is value over time, especially if it is like doubling time or increase significantly. This indicate that is something going on. They need even more imaging. And the response to therapy, the recurrence is very low, like less than 5%, and the death rate less than 1%. If the patient have biochemical incomplete, most of the time, if you follow this, or there will be others. For example, resolved spontaneously, 20% develop recurrence or structural disease. Here, the major issue came from structural incomplete, or there is something in the neck, or something obvious by imaging. 50 to 80% to continue have persistent disease, and nearly all this came from this category, which is recurrence. Indeterminate, 20% will develop structural disease. The management for excellent response, just you can decrease the intensity and frequency of follow-up. Biochemical, just to observe. And those people, most of the time, either most of them or majority, they will tend to be excellent response. They might stay the same or even develop structural incomplete. Additional treatment or ongoing observation depend on their clinical pathological factor. And again, here, observation and monitoring of TG and anti-TG. If you see here in follow-up, it is a dynamic initial risk assessment of death and risk of recurrence by staging and AGCC TNM staging. Ongoing risk assessment, if they have like excellent response, indeterminate, structure, incomplete, we want to see where is the patient from this four category, and then selecting follow-up based on previous risk assessment. A study published like 1 year ago, and what does it show? Here, if we see for example, here in people with like one metastatic lymph node, they don't have any like additional survival change in the survival. But if there is like more than 2 lymph node positive, they found significant significantly, it doesn't change, but multifocal.
Sound, Dr. Naji?
Yes, it changed the survival. And
yes.
intrathyroid, yes.
Yeah, complete.
And ATA low risk, it doesn't change. ATA, yes, survival, but most of these survival, even low risk in those people. So just better overall survival low in those with advanced disease like AGC stage 2. They need like to treat, or they benefit from radioactive iodine. Age more than 55, multifocal extracapsular extension, ATA intermediate risk, and radioactive iodine may not bring survival benefit in patients younger age, stage 1 capsular invasion, or ATA low risk disease. The follow-up of thyroid cancer, how to follow them. Follow-up, recurrence detected by exam, elevated serum thyroglobulin, neck ultrasound, and most of the recurrence occur within 5 years. After 10 years, most of those people low to intermediate risk, they might even not need like long follow-up in the clinic. And operative imaging for thyroid cancer, thyroidectomy versus lobectomy, and thyroid hormone resistant, and is the basic lab for all of those patients plus neck ultrasound. Practical approach of lobectomy or hemothyroidectomy. TSH goal need to be 0.5 to 3, which is almost like lower normal, with or without levothyroxine. They might, most of them, almost 80%, they don't need thyroxine. Clinic visit post-operative to review the pathology, then you can check their TSH and thyroglobulin, then every 6 months follow-up. Then after that for 1 year, then after that yearly for 2 to 3 years with exam. And imaging, neck ultrasound, 6 to 12 months, then after 3 years, and then after 5 years, then after that, very rarely you need imaging, and with people with hemothyroidectomy. Late completion thyroidectomy, if there is physical exam finding, or there is ultrasound finding with this nodule, or there is need radioactive for radioactive iodine, they need to have completion before radioactive iodine. And if there is sustained or severe rise in TG over time. So assessment of cure, almost more than 90% they have cure. And criteria, there is no evidence of the tumor, no imaging evidence, undetectable serum TG in the absence of interfering antibody. And the assessment of cure or remission at initial, and also if there is ablation, and after 6 to 12 months, then after that, probably an annual basis. The last topic or objective, TSH suppression, who and how much. And actually, what they recommend, as a general rule, patients with low risk, they need to be less suppression, very high risk, they need to be high suppression. So if the patient also in response, if the patient have excellent response, low risk, and he is a low risk patient, probably they need even to be even near normal TSH suppression. Or if you see here in the white color, there is no suppression and target from 0.5 to 2. Mild suppression from 0.1 to 0.5, those with intermediate risk or biochemical incomplete or structural incomplete, and moderate to complete suppression like less than 0.1 in very high risk, or if they have structural incomplete. And if you see here, a long time study by Jonah Classett showed that even more suppression, they will have higher survival or better survival. But most of those came from intermediate to high risk. And here a study in TSH suppression in total lobectomy or thyroid lobectomy, like hemothyroidectomy. Do we need to suppress them or no? From the neat analysis, association of TSH maintenance less than 2 and recurrence in people with it was not sufficient and doesn't show significance. So even in people with hemothyroidectomy, they don't need to be suppressed TSH, or the evidence is lacking that if you suppress, it will improve their outcome and survival. So let's go back to our case. This patient is thyroid cancer with 2.5 centimeter. I would like to manage what's her risk. She's low risk. She's stage 1, T2 and 0 and 0. Does she need radioactive iodine? With all of her low risk features, she doesn't need radioactive iodine. I would like to follow her. This patient, she can be followed initially, then after 6 months by ultrasound, TG, anti-TG, TSH free T4, and you can keep her TSH even in the lower side, but not need to be suppressed, like from 0.5 to 2. If the patient, her response is in remission or excellent response, probably can be followed even annually for probably 5 years or so. Then after that can be followed even in her primary health. Okay, thank you.
Thank you, Dr. Naji, for this excellent review of management of low-risk thyroid carcinoma. Please stay for us after the second presentation for answering question. The next speaker is Prof. Abdul Mahfoud. He will talk about management of radioiodine refractory thyroid cancer. Welcome, Prof. Mahfoud.
Thank you very much, Nasser, and let me thank the Society for asking me to speak tonight, and it's always a pleasure to be with you. So our first speaker, Naji, has started in the low risk, and I'll talk about topic 180 degrees from the first topic, which is management of RAI refractory thyroid cancer. As has been alluded earlier, for most patients, surgical treatment, radioactive iodine, ablation, and TSH suppressive therapy achieve an overall survival rate of 98% at 5 years. So this is a fantastic disease to have in a way because it has fantastic survival rate. Local regional recurrence occurring up to 20% and mostly, in intermediate risk. However, 5 to 10% of these cases will develop metastatic disease. And around 60 to 70% of this subset, that is less than 5% of all patients with thyroid cancer, will become radioiodine refractory cases. This represents a really small number, about 4 to 5 new cases per year per million. This state of RAI refractory has significant negative impact on the prognosis on life expectancy, and it does occur more frequently in older patients and those with large metastasis and those with poorly differentiated thyroid cancer and those with high FDG uptake and PET scan. So as you can see here, those who have no radioactive iodine versus those whose metastases take up I-131 iodine, that have a very low survival compared to those who have uptake. As you can see, over the past couple of decades, we have identified a number of mutations that are important in the pathogenesis of those tumors, and those mutations, those oncogenes, have varying degrees of incidence and differentiated thyroid cancer. For example, BRAF is most common in papillary thyroid cancer and anaplastic thyroid cancer, but less so in follicular thyroid cancer. While RAS, for example, have more frequency in follicular thyroid cancer. There are other mutation or such as RET recombination, PTC, 20%. NTARC, for example, is very low at 5 to 10% or less, and the others as well. These are extremely important because some of our mutation targeting those therapy targeting those mutations are available nowadays with great efficacy. So here is the overall scheme of things here. We start with surgery. In some patients, we do need to suppress TSH, as I alluded to earlier. In some patients, radioactive iodine is important. And generally, we monitor those patients. And if there is any recurrence or whatever, we try to do local treatment. And very important to, as much as possible, to utilize localized treatment for those patients, such as surgery, radiation, thermal ablation, and embolization. And of course, if there is bone metastasis, important to use anti-resorptive agents to protect those patients. When all of those are either not effective or progressive despite all this therapy, then kinase inhibitors become important. And these are basically important and should be considered in patients with acceptable performance status, such as performance status 0 and 1. We use them when the other therapies fail or they are not candidates for surgery, or when there is symptomatic disease or disease that threatens vital structure and the clinical significant disease, which is rapidly progressive. Or in patients with biliary thyroid carcinoma who have diarrhea or Cushing syndrome, which cannot be controlled medically. So how do we define radioactive iodine refractory thyroid cancer? So these are patients who have absence of uptake of RAI in all lesions in scintigraphy, or absence of RAI uptake in some but not all lesions, or progression despite uptake of radioactive iodine, and here we're talking significant use of RAI, or reaching the maximum recommended activity on RAI, and here most people believe that 600 millicurie is maximum, or thyroidectomy is not feasible, that surgery will not completely remove, or the patient is not in a good functional status to undergo thyroidectomy. It's very important to realize that those metastases behave differently from one person to another. In some metastases, they hardly move over the years. And we have patients with 20 years metastasis, and they barely increase in size. While some, they increase and they progress very rapidly within a few years. And these are the ones that you really need to act, while those ones are really the ones you just need to observe. I mentioned earlier local treatment as essential to use as much as possible, because treatment with tyrosine kinase inhibitor really is very difficult for most patients, with decrease in quality of life, with an increase in side effects, and also the cost as well. So whether it's external beam radiation, whether it is what do you call it, a laser therapy, whether it is surgery to remove even one or two metastases that are misbehaving. So you may have like bilateral lung metastases. They're all stable except one of them that is badly behaving, going, let's say, to 2 centimeters, 3 centimeters in front of your eye, while the others are really stable. Then you may want to go to do metastectomy rather than using a TKI. Similarly, things like embolization, radiofrequency or cryoablation, and ethanol injection can be used for localized disease. So when do you start or think about using a multi-kinase inhibitor? As I mentioned earlier, evidence of multi-metastasis, progressive disease, and significant progression, not small progression. So if you have a disease that's progressing by 1 to 2 milliliter per year, well, that's not much progressive disease at all. Considerable tumor load. So if you have a lot of metastasis, let's say the lung or whatever, then it doesn't take much to really overwhelm the patient, and therefore you have to act before it's too late, and then the patient's performance status deteriorate that you cannot actually use medication. If the disease involves vital organs, let's say, for example, a disease that is very close, let's say, to trachea, very close to, let's say, a carotid artery or aorta or whatever, you don't want to wait for that disease to go into this vital organs, and then it will be very tough to manage it. And again, as I mentioned, very important to have a patient with a good health status and very few morbidities. So until 2014, we have absolutely nothing to give those patients. And I remember, many years ago, when we basically blindly give patients radioactive iodine, a large dose. All what we did at the time is actually give them side effects of radioactive iodine. We used to call those scan negative TG positive states. And all they got was, dry mouth or myelosuppression or whatever. But they didn't get much benefit until tyrosine kinase inhibitor came in view, and this is the first study, which is sorafenib, and this is called Decision trial, where they randomized 400 patients to either sorafenib twice daily or a placebo. And as you can see here, patients should not have prior chemotherapy or targeted therapy, so they are virgin patients. And here, what you're looking at, progression-free survival. And here are the patients. As you can see, there are 60, and mostly are, of course, papillary with some follicular and poorly differentiated. This is the very beginning. So they included a number of patients of various stages. As you can see here, progression-free survival was much better in the group with sorafenib, reaching about 10.8 months, while in placebo it was 5.8 months. If you look at the response, you can see that the partial response is only 12%. There is no complete response. However, the majority have a stable disease, about 41%. There are the 54% had disease control rate. So overall, therefore, what you're hoping for with using sorafenib is really a stable disease. Now, and here is the waterfall plot looking at sorafenib here in the red or brown versus placebo. And as you can see here, quite a good number of them have either partial response, which is more than 30%, or stable disease, as opposed to placebo, which the majority have progressive disease. As you can see here, those patients who have lesions more than 1.5 centimeter are the ones that actually benefited more than patients who have lesions less than 1.5 centimeter. The second drug that came on the market a year later is lenvatinib. And in this study, which is called the SELECT, they included patients who actually either had previous kinase inhibitors or they did not. And again, they randomized them to either 2-to-1 placebo or lenvatinib or placebo. I believe there is also crossover for patients who have progression and who needed to be treated. And again, looking at those patients, there's 16, and again, more or less similar distribution with the majority of papillary and there is about 10% poorly differentiated thyroid cancer, and there are some with pulmonary, and the majority have pulmonary, and about 40% have bone metastasis. And as you can see here, the progression-free survival is much better with lenvatinib compared to placebo, with the median progression-free survival of 18.3 months in the lenvatinib versus placebo. As you can see here, the curve, lenvatinib much more potent and much effective than sorafenib. And again, if you look at whether the patient had taken TKI or have not taken TKI, the benefit is more or less the same. However, it seems like those who are TKI naive are probably better off than those who are not. Again, if you look at the response rate, there are some who have complete response, about 1.5%. However, the majority have partial response, 63%. Compare this with the sorafenib, which is about 12%. With a stable disease, about 23%. And as you can see, progressive disease is only a small percentage. And the mean time to first objective is really 2 months. Here's the waterfall plot showing the response to lenvatinib, an extremely good response, with the majority having partial response here, as opposed to the placebo, where many are progression. So just compare this for the two studies. As you can see, complete response, more of lenvatinib, partial response, more lenvatinib, significant. A stable disease, as you can see, is mainly in sorafenib. Progression-free survival, again, more in lenvatinib. And when it comes to grade 3 or 4 adverse events, they are much more in lenvatinib. I guess you have everything have a price here. None of them have reached overall survival. Again, when it comes to side effects profile, the sorafenib has hand and foot syndrome is very common, 75%, while in lenvatinib, hypertension is much more common. Diarrhea is similar in both, fatigue more or less similar, decreased appetite more or less similar, weight loss similar, and anorexia and stomatitis are similar. Now, the last one in multi-kinase inhibitor, cabozantinib, this was published only 2 years ago. And again, they randomized 187 patients, 125 to cabozantinib and 62 to placebo. And as you can see here, the cabozantinib group have fared better. I forgot to mention that the inclusion in the study is that for those patients who have either sorafenib previously and progressed on it, lenvatinib and progressed on it, or both of them and the progression. So they don't have any naive patients, and yet they have achieved very good progression-free survival in those patients in a very short time. Again, the waterfall plot showing cabozantinib response pretty good in those patients, while placebo, they have progression. And as you can see here as well, it seems like it works regardless of age, a prior sorafenib or prior lenvatinib, a prior both of them, or no prior VEGF TKI. They all responded pretty well to cabozantinib. Again, looking at the objective response rate, you can see that the partial response is 15%. So it's a smaller response than lenvatinib, almost similar to sorafenib. However, stable disease in 70% and progressive disease only 6%. All right, so these are what we call the multi-kinase inhibitors. So they affect multiple kinase, mainly VEGF, and they are angiotensin. Now, there are many other kinases that are mutation-specific kinases, and one of them is what's called selpercatinib. These are specific for RET-altered thyroid cancer. And you can imagine these are mainly medullary thyroid cancer. However, there are patients with thyroid cancer that have RET thyroid cancer RET mutation. And in this study, which includes both medullary and papillary thyroid cancer, they only have 19 patients in this, and you can see they have different, they include different varieties from papillary, poorly differentiated, anaplastic, and hydrocele. And you can see that many of these responded very well indeed. Some of them, there's 100% response. So the majority have actual, partial response, with very few have stable disease. Again, if you look at the partial response, you're talking about 74% have partial response. This is almost good or better than lenvatinib. And about 20% stable disease. Again, looking at, what do you call it, progression-free survival is about 11 months. Remember, this is phase 1 and phase 2. Another mutation specific is BRAF 600 mutated anaplastic thyroid cancer. Remember, this is a killer disease with mean survival is about 6 months. In fact, it is the worst cancer to have. And generally, many patients will actually die from suffocation. I remember seeing so many patients in the past dying. And there's no adequate treatment for those. In fact, this combination treatment was approved in melanoma patients with fantastic results. And then it was tried in those patients. As you can see, these are 16 patients that were given those patients. And look at the responses. Most of them has partial response. Of course, at some stage, they do escape, just like the other one, these ones, and they succumb to this disease. However, as you can see here, many patients have a treatment duration of up to 100 weeks. These are 2 years. This is unprecedented in anaplastic thyroid cancer, where nothing works. So in this patient, in those combination, there's fantastic response. Very important to use a combination because resistance to one or the other is very high. Therefore, a combination is very important. Recently, and I don't have a slide of it, they actually looked at a combination of those drugs with immune check inhibitors, and the response was impressive as well. So now we're going to have probably a multiple medication used in this aggressive disease with good results. So these are basic. This is the NCT guidelines, where when you have patients which have unresectable or local, regional, or distant metastasis that are progressive, you can use lenvatinib as a preferred regimen. Other regimen is sorafenib. If this or this fails with the progressive disease despite the use of those medications, then you can use cabozantinib. If you're lucky and you have mutations detected in your patients, such as larotrectinib, such as NTARC gene mutation or RET gene fusion positive tumors, or BRAF 600 in poorly differentiated thyroid cancer anaplastic, then it is important to use those medications if they are available. These are very expensive medications. You're talking about $1 million per year. It is interesting to talk about this. Now on the floor, we actually have one patient. It's the first patient that we have on NTARC inhibitor, larotrectinib. In fact, this lady has papillary thyroid carcinoma with lung and bone and brain metastasis. This is a patient of Dr. Zahrani, and she has an impressive response to therapy. We have another patient, young patient, again with disseminated disease and brain metastasis, and she's been on selpercatinib for a number of years, and she's doing pretty well. So it is extremely important to remember that tyrosine kinase inhibitors are cytostatic and they are not cytocidal. They are not curative, so continuous therapy is necessary to maintain a response. Side effects with multi-kinase inhibitor may reduce patients' quality of life, and medication may have the potential to cause harm. I can tell you, everybody I gave those patients to, they really suffer. They have decreased appetite, they have weight loss, they develop diarrhea, they really feel miserable. They're not a nice medication. But when you have no option and the patient's in front of you, being seen going southward, it is important to stop it. The clinical benefits last for a limited period of time, and the disease will invariably progress over time. So the response may last a year, 2, 3, 4 years, and then you have to shift to another medication. And with time, of course, we're going to have more medication that we can use when those medications fail. We have a patient, again, who's interesting, medullary thyroid carcinoma with Cushing's, who have done very well on selpercatinib and started to actually progress, and now he's on cabozantinib. He's not happy at all because of the side effect. The mutation-specific inhibitors are very well tolerated. I have a patient, selpercatinib, with disseminated medullary thyroid carcinoma. He has absolutely no side effects, and his quality of life improved dramatically. So those mutation-specific are very well tolerated, unlike the multi-kinase inhibitors. As I mentioned, all of them had side effects. I mentioned some of them, there. So the skin rash in the hand and the feet, the hypertension, the diarrhea, the fatigue, just miserable, feeling miserable in almost all of the multi-kinase inhibitor, VEGF inhibitors. Again, there is many contraindication to their use. So they have high risk of bleeding and fistula. So, for example, in patients who have tumor invading the trachea, bronchus, or pharyngoesophageal tract, there is a risk of fistula. Some of them have who have cardiovascular risk. Hypertension, extremely important with lenvatinib especially. You really need to see them quickly, within a week or two. I never see them say, see you in a month or whatever. I see them early, within 2 weeks. Make sure that you do the urinalysis for those patients. Many of them will develop albuminuria, and you need to treat them. We have a patient who unfortunately came and developed stroke of severe hypertension because he missed his appointment. Very important to do QTC interval when they are on those medications. And when you see the QTC more than 450, you may have to stop and restart. By the way, many of those side effects that I mentioned, what you need to do is actually reduce the dose or stop them and reintroduce them. Some of those side effects may not recur. Again, with cachexia poor nutrition, you really need to see if you can help them with some nutritional supplements. With brain metastasis, the risk of bleeding is there, and you're really at a loss between, between a rock and a hard place. What do you do in those situations? And with that, I'll thank you for your attention, and we'll be happy to answer any questions.
Thank you, Dr. Mahfouz, for this excellent presentation about radioactive iodine refractory thyroid cancer. So now, both of you, Dr. Naji, Dr. Mahfouz, will ask them for question. So please submit your question to the Q&A panel. The first question, maybe Dr. Naji or anybody can answer it. Would fellow micro papillary thyroid carcinoma as low risk or consider as pre-malignant? And the same question also in IFTP, could we consider it pre-malignant? So in micro papillary thyroid carcinoma less than 1 centimeter. Dr. Naji, you want to answer? Or?
Yeah.
Your voice.
Micro BTC is malignant. However, NIFTP was reclassified as pre-malignant. And it is not even low risk, even below the low risk. So it is pre-malignant condition.
Okay. So maybe we'll not consider surgery in papillary microcarcinoma.
Papillary microcarcinoma, there is no
Practical point, I know, yani, but
we can be just treated as active surveillance. However, we need to provide patient perspective, medical team for follow-up, as well as the patient criteria. If he fit the criteria, he can have the option that for just only active surveillance.
okay.
If I come here, I agree with Naji. I mean, this study comes from Japan and US, where follow-up of patients with microcarcinoma for 10 years, the vast majority, over 90%, did very well without even lymph node metastasis surgery. However, I just wonder how many patients, if you tell them they have cancer in their neck, will be happy to just follow it. In fact, I had a physician who, he should be able to balance the benefit he risk. He said, if you tell me, I have cancer in my neck, I would be running straight to the surgeon. I think the important thing is why would you do an FNA in a nodule that's less than 1 centimeter? Unfortunately, there are people who cannot sleep on it, either physicians or patients. They want to know what it is. And this is when you get into this situation. But again, very important patient perspective. As I said, many patients may not want to sleep on it. So if they don't want to sleep on it and they cannot sleep thinking about it, well, then you have no choice in that matter.
So you will
just Dr.
You will do for them.
Dr. Nasser, just I want to add. Now, there is several studies. One of them was in the 80s, in the last decade, 1984. It showed that, done by a pathologist. Actually, what he did, he looked for those people post-mortem for any reason, and they just take their thyroid slice and see what's the prevalence of incidental thyroid cancer. It was almost 5%. So even micro PTC, they live with it. But again, it needs perspective from medical team, patient acceptance or preference, and as well as follow-up. It can be done, yes.
There is a question or comment from Dr. Iman Siddiqui. She said, lymphatip is more effective than surfani. So what's your opinion? Which one you prefer?
So as you can see in the NCCT recommendation, the lenvatinib comes first before sorafenib, because of its efficacy. You saw the progression free survival 18 months versus 3 months, as compared to sorafenib 11 months versus 6 months almost. Similarly, the partial response in lenvatinib is about almost 70%, while it's only about 12% sorafenib. So there's no doubt about it that lenvatinib is more efficacious. However, at the end of the day, it's what you have there and what you're familiar and what you're comfortable with. The side effect profile is different, and some people prefer one over the other because of side effect profile. But overall, if you have a patient who really have a lot of progressive, aggressive disease, you want to go for lenvatinib. Especially if those patients have neck disease that is encroaching on vital organs, and the surgeon say, I cannot really remove it, and you want something to really address, and you want to go for lenvatinib. The other thing is, in the use of those drugs, is it might change a patient's status from non-operative to operative. It's like cytoreduction. You reduce the tumor, and therefore you make it easier for the surgeon to remove it. And here you need lenvatinib, because lenvatinib has a much better reduction inside of those patients.
We have actually a lot of a question. This is mean that interested in the topic. Dr. Naji, what is the cutoff point of thyroglobulin if the patient did lobectomy for thyroid cancer? Because before they said 30 now, what do your opinion or ultrasound use? Dr. Naji, your sound is not, voice is not heard.
Yes, now is it clear? Yes,
Yes.
for follow-up, they need ultrasound for the other lobe as well as, and if there is any lymph node or suspicious lymph node. Plus, they need also the thyroglobulin with the same level of TSH in follow-up. In general, less than 30 will be reasonable. However, if it came increasing just or the same or within the same limit, but if it is doubling, for example, if you find it 30 now 80, or there's something going on. If ultrasound doesn't show, you might even do other imaging to make sure that there is no recurrence. But in general, less than 30, most people, they will do fine.
So it will depend on ultrasound, isn't it?
Ultrasound and the level and over the decline or increment over time.
You said most of the recurrence of low papillary thyroid cancer will be in the first 5 years. So how we follow up this patient? Yani, how frequently we follow up in the first 5 years and then after 5 years?
Their risk, number one. Number two, their response. If they are in remission, they can be seen within the 5 years annually. After 5 years, if the patient is still in remission, there is no guideline to support either to follow. There is debate. Some of them, they just no need for follow-up. You are almost close to baseline. And some of them, yes, you might even like more duration. However, as practical point, after 5 years in endocrine clinic, in patient in low risk, in remission for the last 5 years, he can be followed like in annual basis, even in his primary healthcare physician.
Okay. The next question for Dr. Mahfouz, TKI, can be TKI used indefinitely? Yani for how long till the, yani is it continuous patient improved, for example? Yes.
So number one, the TK has been with us since 2014, so it's only 9 years. Two, as I mentioned earlier, if you stop them, the disease starts growing. So they are cytostatic, not cytocidal, which means that you have to continue using them as long as you have a response. If you lose a response, that is, you have progression despite being on them, then you have to switch to something else that is available. So sorafenib, you go to lenvatinib, you go to sorafenib, both of them you go to cabozantinib, mutation specific, you're going to the other. So yes, absolutely, these are not cytocidal. These are not something that you would take today for a year and the disease disappear. No, they will just keep it at bay. It will, as you've seen in the lymphatic trial, only 4, which is 1.5%, have complete response. All of them have partial response or stable disease. So if you stop them, you basically lose your benefit. It's almost like talking about hypertension and diabetes. The fact that you have a response doesn't mean you stop them. You continue using them.
What's the absolute contraindication for kinase inhibitors? Any absolute contraindication?
Poor functional status, definitely not. Okay. Bleeding tendency. There are morbidities, bad morbidities. You should not use them. How can I say? There are quite a number. I cannot recall, but if I see them, I'll recognize whether they are or they are not.
Maybe the question, both of you, Dr. Naji, if the patient has positive anti-thyroglobulin antibodies, we cannot use thyroglobulin as a marker of recurrence of the disease or persistence. So what do you do in this situation? The anti-thyroglobulin antibodies positive. Your voice, please. Yes. Dr. Naji, you cannot hear you. Dr. Naji, can repeat? Yes.
Follow them with serial anti-TG. If this is going up, it means that this patient most likely having a recurrence. If it is decreased over time, this is great. And also other imaging, for example, like ultrasound or other imaging if you suspect there is a recurrence. For example, if the patient have initial anti-TG, we expect within 2 to 3 years, the average to return to normal. However, up to 10 years, still they have persistent anti-TG in some of the study. So those, just we follow them with anti-TG, and keep in mind, anti-TG reflect the TSH. For example, if TSH stimulation, anti-TG will go up. So this is not accounted. So the same level of TSH and anti-TG just follow up. If declining or stabilized, this is great. But if it's going up, indicate that there is something going on.
Excellent. Any indication for stimulated TG in low risk thyroid cancer, or we use suppressed oral treatment? So
if you have in the lab high detectable TG will be more than enough. But if not, you can just use stimulated TG.
So suppressed TG give you 99% prediction that you're fine. You still miss 1% where if you stimulate, you will get a much higher thyroglobulin. But that's probably not clinically significant in those patients.
So we use suppressed and thyroxine for follow-up of this patient, isn't it?
Yeah. Yeah, and actually our lab nowadays is very sensitive for thyroglobulin. In the past, no, but now it is very highly sensitive thyroglobulin.
There is one very important question, maybe both of you give opinion. What's the rule, and this is usually confusing in clinical practice, what's the rule of radioactive therapy, radioactive iodine therapy in intermediate risk thyroid cancer? Sometimes some say give, some doesn't give. So what do you think? Definitely I will give this patient intermediate risk, I will not give. So we'll hear it from Najid and Dr. Mahfoud. Yes.
For any patient, for example, if there is like presence of lymph node, especially if it is like what we mentioned, not less than 5, more than 5, or large lymph node, for sure. If there is gross extrathyroid extension, for sure. If there is other like multiple, not just only vascular invasion, but there is other multiple. So if you calculate the risk, if you want to calculate, use different risk. For example, ATM, if there is stage 2 or 3, yes, for sure. And those people, if they have something beyond even classification, for example, if the patient very high risk, he exposed. We rarely found those people, but if he was exposed to external beam radiotherapy in the past, or any radiation in the past, or if the patient have significant family history, or if there is also mutation like TERT or BRAF or other. So those, for sure, we prefer to give them radioactive iodine as intermediate risk.
Dr. Mahfoud, any, for example, patient come columnar cell, or patient come with capsular invasion, when you find capsular invasion, vascular invasion, we give them radioactive iodine or not? So what's
Yeah. So again, here is case by case basis. You know, you can put a broad category, but really it's good. So let's take an example: somebody having 1.5 centimeter tall cell tumor, but it's within the thyroid, completely removed, superb surgery, no extrathyroid, nothing. Yes, this is an intermediate, but the patient is cured by surgery, because there's no other thing. Here is another example that will tell you. Here is a patient with, let's say, 3 centimeter, microscopic extrathyroidal extension, a couple of lymph nodes maybe here, what they call it, surgery, not that adequate, still remnant here or whatever. You collect all of this, thyroglobulin higher than you want it to be, okay, that will push you to give RAR. So it's a case by case. It's not just intermediate give or not.
Capsular invasion, Dr. Mahfoud, what do you think about capsular invasion?
Yeah, again, I don't think it's an issue as long as you have a complete removal within the thyroid. If you don't have anything else, I wouldn't worry about it. A small, completely removed, you know, I wouldn't worry about it. This will be low intermediate risk. There is intermediate risk, really a long spectrum from a low to high. And if it is a low intermediate risk, the other thing is very important is this patient going to be followed by you, or is he going to disappear somewhere where they don't even have thyroglobulin or whatever? I think that, to me, I know this is not science, but I think it's logistical, practical approach, where if you know you will not be able to follow this patient, the patient may disappear, or the patient will go to a place remote, there's nothing there, maybe it will push me to really give him the benefit of the doubt. I know this is not science, but rather than it is a sort of a personal sort of bias.
Need multidisciplinary team discussion. Dr. Naji, what's the indication for radioactive iodine in low risk? You can give low risk radioactive iodine, or your choice, please.
Yes.
Yes.
So yes, for example, as mentioned by Dr. Mahfoud, sometimes like surgery inadequate, like when you do scan, there is like large remnant. Those we give them, even though they are low risk. If there is still evidence of if you remember, if they are not in excellent response, most of the time, they need follow-up or radioactive iodine. If there is like multiple risk factors, for example, capsular invasion, vascular, together, yes, or the patient very high risk, other than that, the pathology. However, those to give or not to give, it depends if you follow the patient or no. This thyroid cancer is low or less aggressive, not like other cancer in most of the cases, especially with differentiated thyroid cancer. If you have like other pathology, for example, columnar or other columnar or torsil, they have slightly aggressive cancer, though you might be in the position to give them even lower dose radioactive iodine.
We know that.
Sorry, let me just say something. All the guidelines are assuming the patient has an excellent surgery. It is extremely important. If the patient did not have excellent surgery, then you put the guideline aside and look at the patient, see what they have left. We have given patients with what appear to be a low risk patients radioactive iodine. Why? Because they have a lot of remnant. You don't want to go to surgery with and already have, for example, recurrent laryngeal nerve. It looks like a normal thyroid, but a few little nodules here and there, and the patient is not candidate for surgery. And even the pathology said 1 centimeter, you may want to give those low-risk area because they just didn't have adequate surgery. And you don't know what is left there and the patient's neck. So again, individualize and take this into consideration. Guidelines are for patients with excellent surgery, not for patients with really inadequate surgery.
You know that ultrasound of the neck is operator dependent, and in one study, actually up to 60%, they found false positive. They said there is a recurrence in the neck, but actually is not. So in this case, what you will do, if you find some finding in the thyroid bed or lymph node, when you are worried, and what you do next regarding the lymph node size, regarding the abnormality you will find in thyroid bed after ultrasound. So what next you do? Dr. Naji, please make the mic near you, yes?
Yeah. If there is suspicious lymph node, for example, cuboidal in shape, or there is calcification or cystic changes, ipsilateral, multiple, compressing artery or vein, or displacing other structure. These we just will proceed with FNA. Even if they're TG negative, we proceed with ultrasound guided FNA. If these tend to be positive in suspicious cases, we refer them for neck dissection.
Okay.
It is, this is the biggest problem sometimes we face when we say to the patient, goodbye, go back to your institution, and somebody does ultrasound, and then, like you said, that's something there. The most important thing to look at is actually thyroglobulin. If the thyroglobulin, anti-globulin antibody is low, undetectable, excellent response, then you can reassure the patient specifically if what you see is something transient or small. Something less than 1 centimeter, you still don't want to do anything anyway. And I mean, like in the narrowest one. If something comes up as a lymph node and higher up, ask the patient. Maybe they just had what they call it an upper respiratory tract infection or whatever. Maybe you just want to repeat it in 4 to 6 months, 4 months, and see what happened. As long as the thyroglobulin is undetectable, and this patient has had what they call it a low risk, clear for many years, you have the time to sort of watch and see rather than put him through this FNA, etc. Of course, if the ultrasound is strongly suggestive that this is a recurrence with, what Naji mentioned, very worrying signs, then that's a different matter. But if the TG is low, antibody is low, and this is just one lymph node high up in the neck, maybe you want to repeat it in 3 months or so.
Regarding that, you mean you will do stimulated TG in this case, or you will depend suppressed TG? For example, post-operative 3-4 months, you find some changes in the neck. You will do radioactive iodine diagnostic screening. You will do stimulated TG, or you will repeat again and in suppressed in thyroxine suppressive therapy?
So that's for me. So generally, whole body scans generally once it becomes negative, and again, some people don't do whole body scan after treatment. We do it. Once you give RAI, for the most part, whole body scan will be negative, even in some of those who have distant metastasis. If you give RAI, the neck disease will almost disappear in terms of uptake. So I would not do a whole body scan as a diagnostic thing. If the thyroglobulin is low, less than 0.1 and detectable, I don't think you will be, how can I say, you will get more mileage by stimulating thyroglobulin. Okay, you stimulated it, it's GAMP2 or whatever. So what? It doesn't tell you anything. I think you're basically stuck with the imaging and and what is your pretest likelihood? If your pretest likelihood is low, this guy is fine, then back off and just watch. If your pretest likelihood that this is probably a patient that may have recurrence persistent disease, especially early after surgery, then you go after it. If it's a few years, like 4 or 5 years later, and you're confident there is nothing, you can sort of have the time to watch and see.
Regarding refractory radioactive iodine with lung mets, which you prefer first, surgery or TKI?
Lung mets?
Yeah.
Well, in general, lung mets usually they don't occur as one lesion, but sometimes they do. So let's say somebody has one lesion. Let's take it an example, which doesn't occur that frequently. It has one lesion that's grown, and it reaches about 3 centimeters, and nothing else you can see. Then I would go for metastatectomy. I'll tell you why. Because I've seen so many people we give TKI, and they really suffer. It's not nice, and it doesn't remove it. So if the patient's in excellent health and no morbidity, I would go for metastatectomy. Even if there are a few little ones there, if they are stable over years, and this is the only one that is an outlier, I might go for metastatectomy and watch those, because you may go on for 3, 4 years before you need to come and start TKI. If there is more than one and they are big, no, that's a different matter.
There is one repeated question after lobotomy. They said thyroglobulin cut-off point of 30 they use, but it is not reliable, so it will depend on radiology mainly, isn't it, Dr. Naji? It will depend. Your voice is far away. Please, you can make the mic near you.
Ultrasound as well as the increment of thyroglobulin. Like if this increased significantly or no. For example, if it was even 20 and now became 50 or 60, etc. So just you will see either stabilize or it will stay the same.
We take a longer time than allowing, but it is really, if it is good for you, I will continue. Is it good for you? Is it good to continue or stop here?
If there's 1 or 2 questions, will be fine. But
okay. If thyroglobulin antibody is suppressed and thyroglobulin is high but less than 20, ultrasound bit free from residual or recurrent disease, what's your recommendation? So thyroglobulin is positive but less than 20, and ultrasound NIC was negative.
The patient hemithyroidectomy.
La, this is maybe total thyroidectomy. They don't mention. This is total thyroidectomy, most likely. So thyroglobulin less than 20, ultrasound negative. What next? Positive, but less than 20.
And what's the scan does it show?
You will proceed with the scan. You will do CT. What you will do?
Well, this patient receive radioactive iodine or no?
They didn't mention.
Because the question just only they give figure.
Maybe not.
If the patient receives radioactive iodine, it will show if there is any residual or no. If not, we will just proceed with PET-CT, especially if the TG positive.
So what you will do in this case? You will do radioactive iodine diagnostic, or you will do more radiology, or
we will see. We will do just more radiology because we want to see from where is, or just only biochemical incomplete, because even TG is positive does not necessarily mean recurrence. Up to 50%, this is just only positive TG, but with time will be decreased or disappear. So just we want to see if the patient have negative scan and other imaging also negative, just we will observe and we repeat imaging for 6 months as well as their TG and anti-TG.
So
Biochemical incomplete.
TG of 20 suppressed is incomplete response and usually indicate disease recurrence, assuming the patient has complete surgery and RAI, and in the post-RAI evaluation initially was negative and then became 20. This means there is a recurrence. If the patient did not receive RAI and has a complete surgery and there is a thyroid of more than 20, there is probably either a remnant, what do you call it, normal remnant, or disease persistence. Here you need to look for disease, and usually you're going to look for disease in the neck. The best way to do it is ultrasound. If the ultrasound negative, you go for the CT neck. If the CT neck test is negative, you go for PET-CT. So imaging, structural imaging in the neck is very important. Now, if the patient did not have, what do you call it, whole body scan, if he does not have RAI, I certainly would do a whole body scan, definitely. Because here we're talking about a disease or recurrence or persistent, and therefore you need to do it. If they had RAI before, then I don't think I would do another whole body scan unless you suspect, disease that take up RAI.
The last one or two questions. If the patient develop severe side effect to multi-kinase therapy or tyrosine kinase, do you stop the treatment?
So there is, yeah.
Or you restart?
Yeah, so in general, what's been done is either you reduce the dose and see what happened, or stop it and restart it at a lower dose. Let's take an example of hand and foot syndrome rash. Generally, it is bad. If it is bad, like 3 or 4 adverse where the patient cannot use their hand, you stop it, of course. If it's mild, maybe you can reduce the dose. Similarly, things like, patients sometimes, they say, I'm losing weight, I cannot eat anymore. Well, you stop it and reduce it at what do you call it, at a lower dose. And if you go up and the same happening, well, you have to be happy with half the dose. Linvatum 24, you go to 10, 14, if they can tolerate 10, 14. So you have to really recognize patients, what do you call it, complaints, because you're really going to reduce the quality of life, and the side effect can be worse than the disease itself. And therefore, you either have to stop it or reduce the dose, restart it at a different dose, and so on.
One last question. Any rule for ablation with microwave or radio frequency and recurrence or lymph node metastasis? This is from my dear colleague, Dr. Wea. Any role? Microwave or radio frequency?
Yeah. Again, this is if if there is one lesion. Let's say you've had a patient that had 3 surgeries and they still have that lymph node come up, etc. You have the option of using alcohol injection or radiofrequency ablation. Similarly, if you have a lesion somewhere else, even if you have 10 lesions and one of them is badly behaving, you can do radiofrequency ablation or cryoablation or whatever. Another situation where you have an endotracheal lesion, okay, and you cannot give tyrosine kinase inhibitor because of the risk of bleeding. You can do cryoablation, you can do laser therapy if it's endotracheal. So you can do local therapy, and you don't have to go all the way to TKI. And you can use a combination. I use a combination, let's say external radiotherapy in one area and radiofrequency in another area to really put back the time to use TKI. Yes, you can use, and you can use any combination.
So give us, Dr. Naji, last recommendation from your side. Do you use diagnostic whole body scan in low-risk cancer? You use it or just
in low-risk patient in general they don't need, just only TG, anti-TG, and ultrasound. will be more than enough. It will detect more than 98% of the cases. They don't need. If you suspect or there's TG positive or other or TG, anti-TG positive or persistent positive, yes, you can proceed with diagnostic whole body scan. Then you can go from there.
Okay, so will depend on suppressed TG in follow-up, isn't it? So when you will worry about what cutoff point you will worry about recurrence or persistence of the disease, cutoff point of suppressed.
Even TG, suppressed TG, even 1 is positive. This is like high. Even more than that would be high. So those people, they need to have other imaging apart from, even if ultrasound negative, they want to see, at least to see if this patient having persistent disease or not.
Dr. Mahfouz, the last question. When you will say this is radioactive iodine refractory thyroid cancer in your practice, when you will say I will start take AI or whatever, when?
So either a local disease that is not amenable surgery, even from the start, patient comes with a very aggressive disease and they're not candidate because the surgeon says no, or you have a distance metastasis that you've given enough RAI and the scan is negative, no longer positive, and it's a progressive lung. The common one is lung metastasis. You do the whole body scan, I123, I131, and there is nothing there. And the metastases are progressing. This is radioiodine refractory disease. Or some of them take up a little bit, most of them not taken. This is RAI refractory disease. And when, the issue is when, you know. So you don't want to start them too early, but you do want to wait late that their performance status does improve, that you can start it. So you have to be a sort of juggle your choice. So when they reach a certain size, and usually lung, we're talking about more than 1.5 centimeter each. Okay, then you start introducing TKI. Something small, 1 centimeter, even if they have 20 of them, you're not going to do anything. As long as they are not really, what do you call it, coming very close to vital organ. And again, if they are stable for a while, let's say 5 years, they're really progressing very small, and suddenly they're taken off. You need to do the CT within 6 months, not within a year or whatever. And any sign that is really going faster, then you have to introduce the TKI.
In the behalf of the Board of Directors of Arab Thyroid Association, I want to thank both speakers, Dr. Mahfouz and Dr. Naji. Also, I want to thank our audience, and will not forget to thanks the team of the ICOM with a special thanks for Mr. Ziad. So thank you very much for this interesting presentation and discussion, and see you soon in other Arab Thyroid Association update webinars. Thank you for you.
Thank you very much. Good to be with you. Good night. Have a nice week.